Good morning, dear colleagues. My name is Andrei Varvinsky. I'm a consultant anaesthetist at Torbay Hospital in the United Kingdom in the southwest of England. And today it is my pleasure to talk to you about local anesthetic toxicity for your continuous European education in anesthesiology. Okay, without further ado, let's start my presentation. It's going to last, hopefully, not more than 30 minutes. What is the incidence of the local anesthetic toxicity? Let's look into that first. In 1928, American Medical Association first reported the 40 deaths related to local anesthetic toxicity. And half of them were related to cocaine, and sometimes they were related to procaine, which is mostly known to us in Eastern Europe as Novocaine. But its actual name, the generic name of it is procaine. Then in 1979, somebody called Albright reported 6 deaths from amide type local anesthetic, namely bupivacaine. And in 2010, Gregoria published a report of 93 cases covering the period from 1978 to 2010. NAP3, this is the National Audit Project of the Royal College of Anaesthetists, who looked into major complications of a central neuraxial block in the United Kingdom, found 11 cases of intravenous administration of local anesthetic per year per 700,000 spinal and epidural anesthetics, giving an incidence of 0.000015. And in 6 cases out of the 11, bupivacaine was involved. I'll give you this case first so you can see how devastating this problem could be. This is 11th of May 2004. This is a publication in a local newspaper, which is titled Epidural Drug Death. Mother was unlawfully killed. And this is the case of a 30-year-old nurse from Philippines who 45 minutes after delivery of a baby, successful delivery of a baby under epidural, suddenly felt dizzy. She lost consciousness. She developed seizures. And then 3 hours later, she died, despite all the efforts to resuscitate her at Swindon Hospital in Wiltshire. And then they found that a bag of 150 mils of bupivacaine was attached intravenously instead of epidurally. It's slightly strange because usually after delivery of the baby, the epidural is disconnected. 6 years later, in 2010, hospital was fined for £100,000 after wrong drug killed new mother. Hospital admitted the mistake, and although there were 2 similar cases in 1994 and 2001, and measures were taken where they installed a separate cupboard for local anesthetics. So only local anesthetics were kept in that cupboard, no other medications. Don't know how they were trying to prevent that. But when they moved into a new hospital in the same city, the measures were not renewed. Well, let's try and classify the local anesthetic toxicity. It could be broadly classified into local and systemic toxicity. And let's talk about local a little bit first. It is usually the toxicity related to metabolite of amino esters, procaine, which is a paraminobenzoic acid. It could be myotoxicity caused by local anesthetic. It could be neurotoxicity caused by some of them, which is attributed to a 5% lidocaine in the past. It could be transient neurological symptoms due to excessive long block, or it could be anaphylaxis, often to amino esters due to preservatives that they contain, like methylparaben or metabisulfates. But today we're going to talk mainly about systemic local anesthetic toxicity, otherwise is known as LAST, local anesthetic systemic toxicity. Let's talk a little bit about the structure of a molecule of a local anesthetic. And this is the classical representation where you have three parts of a molecule of a local anesthetic. One is the aromatic part, which is lipophilic. And then another one is amino group, which is hydrophilic. And in the middle is the intermediate chain. And it's the shape of this intermediate chain that determines which type of local anesthetic this is. So the mechanism of local anesthetic toxicity depends on several factors, several structures of this molecule. For example, lipophilic aromatic ring has an ability to penetrate the membrane, cell of the membrane, and hydrophilic amino group interacts with protein receptor, determining the duration of action of a local anesthetic. An intermediate chain determines the potency, so how potent, how strong this local anesthetic is, but also it determines the toxicity. And it's also determined by the number of the carbon atoms in the molecule. And these are the examples of the amino esters and amino amides. Amino esters are cocaine, benzocaine, procaine, tetracaine, chlorprocaine, which chlorprocaine, as you probably know, is now available as the ultra-short acting anesthetic for spinal anesthesia in particular, but mainly we use these days, we use lidocaine, prilocaine, bupivacaine, ropivacaine, levobupivacaine, which are all examples of amino amides type of local anesthetics. Main local anesthetic properties is the speed of onset, and the speed of onset is determined by something called pKa, which is the dissociation constant. And pKa is determined as the amount of local anesthetic that is 50% ionized and 50% unionized, which is important because the more only the non-ionized portion of the local anesthetic can actually penetrate the membrane, and then it turns into ionized portion, which then blocks the sodium channels from within the membrane cell, and this is how the local anesthetic work to stop the propagation of the nerve impulse. And the potency or fat solubility, as we said, determined by protein binding, and the potency is determined by procaine, because procaine was one of the first local anesthetic, and we class procaine potency as 1, and compared to procaine, bupivacaine is 6 times more potent than procaine or novocaine. And duration of action is determined by binding to proteins. Sorry, potency is determined by fat solubility, by lipid solubility, and duration of action by protein binding. A systemic local anesthetic toxicity is also determined by fat solubility and protein binding capacity. So the more fat soluble they are and the more protein binding, the more toxic they are. Local anesthetic with low protein binding, like lidocaine and bupivacaine, are more dangerous in the development of LAST. What happens to the local anesthetic in the body? What is the pharmacokinetics of the drug? So in other words, what does the body do to the drug? The local anesthetic is injected near the axon of the nerve, and then you have non-specific local tissue binding, and then the local anesthetic is absorbed to the bloodstream, and from the bloodstream it's metabolized by plasma cholinesterases, or depending on which type of anesthetic they are, or it goes to liver and metabolized by cytochrome P450 and excreted. And obviously from bloodstream it also can go into other vascularized organ like brain, causing local anesthetic toxicity, heart, causing cardiovascular toxicity, and other tissues. Pharmacodynamics, what does the drug do to the body, in other words? It blocks not just the sodium channels that we spoke, but other channels like calcium channels, potassium channels, and sodium-potassium ATPase channels. It also blocks the production of ATP, and it blocks ryanodine receptor. What is the mechanism of local anesthetic toxicity? It does, because local anesthetic also affect conduction by direct blockade of sodium channels, mainly in the bundle of His. That's how the cardiotoxicity could be developed. It also decreases the membrane potential at rest. That causes the impairment of action potential conduction, which leads to prolongation of PR, QRS, and ST segments. That all can cause re-entry tachycardias and bradycardias. And by blocking the potassium channels, it causes the prolongation of the QT interval. Also blocks the calcium channels and sodium calcium pump, reduces intracellular calcium stores, and causes the myocardial contractility reduction. Also causes neurotoxicity, where the increased concentration of local anesthetic will affect cortical inhibitory pathways by blocking sodium channels and impairing inhibitory depolarization of the neurons. All that leads to excitation and seizures, with increasing concentration of local anesthetic, suppressing the excitatory pathways, depressive phase with development of coma and respiratory arrest. What are the factors that actually influence the development of the local anesthetic toxicity? There are three major parts: local anesthetic properties, administration techniques, and patient factors. Okay, let's look at these three items in turn. Local anesthetic properties. Some of them can have vasoconstrictive properties, like in particular cocaine, which is still used for that properties, when as part in its own or as a part of the Moffat solution, where we mix it with sodium bicarbonate and adrenaline, and it could be instilled by the syringe into the nasal cavities for nasal surgery, for example. Stereoisomerism, so local anesthetic, like for example bupivacaine and levobupivacaine are similar to each other, but because levobupivacaine is only one L isomer of bupivacaine, and bupivacaine being the racemic mixture, that changes the properties of this drug dramatically, where all the bad effects, all the bad side effects disappear, but all the good local anesthetic effects, main effects, appear. It's the same principle for many other drugs, like, for example, ketamine. Ketamine is the racemic mixture of L, R, and S type, and S type, S-ketamine, which is now available, is got all the good properties of ketamine, but less side effects. And also there is an addition of vasoconstrictors like adrenaline or phenylephrine. This is what we spoke about. So on the right side, you can see levobupivacaine, which is you can think of it as a half of the molecule of your bupivacaine, but in fact is just levo rotating isomer of bupivacaine, which has all the same properties of bupivacaine, if not slightly weaker, I suppose. But if you inadvertently inject levobupivacaine intravenously, the development of the local anesthetic toxicity will be a lot less. This is why we pretty much in our hospital switched from bupivacaine to levobupivacaine a few years ago. And if we compare the most widely used local anesthetics, amide types, ropivacaine, levobupivacaine, and bupivacaine, by their lipid solubility, for example, you will see that levobupivacaine and bupivacaine are exactly the same. Protein binding are exactly the same in all of them. pKa is exactly the same. Partition coefficient is half of ropivacaine, and lipid solubility is very low in ropivacaine, which means that ropivacaine got almost the same properties as bupivacaine and levobupivacaine, but because it's less lipid soluble, it is less potent. So that's why it will, well, some people say, causes differential block, which means it will cause a good local anesthetic block, for example, if you use it epidurally, but there will be a lot less motor block. But if you actually give the equipotent dose of ropivacaine, the same thing will happen. So it's just a weaker type of anesthetic purely because of lipid solubility. And this is how, knowing the properties, the physical properties of the local anesthetic, anesthetics, you can, or many other drugs, you can actually predict the effect of those drugs. There is this thing called cardiovascular CNS ratio, and this is the ratio of a drug dose causing catastrophic cardiovascular collapse to drug dose causing seizures. Okay, so the lower the ratio, the more cardiotoxic drug is. For example, for bupivacaine, it's 2. For lidocaine, it's 7.1. So lidocaine will cause a lot less local anesthetic toxicity, cardiovascular features of it than bupivacaine. The higher this ratio is, the earlier the CNS toxicity will manifest before the onset of the cardiovascular abnormalities. And we'll talk about which one will start first. So the treatment starts sooner if you see the CNS effects first. You will then act before your cardiovascular effects will appear. So levobupivacaine, for example, and ropivacaine, both of them have CNS cellular uptake is lower in both of these drugs. Convulsive threshold is higher, and they're 7 times weaker potassium channel blockers, reducing the risk of the QT interval prolongation. So they have lower risk of arrhythmias compared to bupivacaine. And cardiovascular CNS higher than bupivacaine. So their CNS effects will appear quicker. So you will then act quicker for treating the local anesthetic toxicity, and they have slow absorption. Administration technique, if you inject intravascularly, like lidocaine is injected, but luckily it's less toxic, then obviously you will have local anesthetic toxicity symptoms pretty quick. If you exceed maximum dose, you will be at risk of developing LAST. Speed of administration, increased pressure around vessels, penetration into vessels, needle displacement, all that, excessive volume, all that matters. And administration of local anesthetic by non-anesthetists has been proven to have some effect on the incidence of development of LAST. This is the ASRA, American Society of Regional Anesthesia, recommended dose, and they maximum doses of local anesthetics for bupivacaine, for levobupivacaine, for lidocaine, for mepivacaine, ropivacaine, and prilocaine. You have a maximum dose without adrenaline and maximum dose with adrenaline. And they recommend to calculate on lean body mass rather than actual total body mass. Plasma concentration of a local anesthetic depends on the site of administration. Obviously, if you inject intravenously, it's highest, then intrathecal, then goes intrapleural, then goes intercostal, then goes paravertebral, caudal, epidural, plexus, and subcutaneous anesthetic injection of a local anesthetic will have the least effect on development of local anesthetic toxicity. Upper extremity blocks are more common than lower extremity blocks in terms of developing LAST because there are more major vessels around, I suppose, and there is more frequent with the catheter. If you insert the catheter into a particular perivascular compartment for a plexus type block, then the chance of developing LAST is higher than the single injection. And also local anesthetic technique where you use local infiltration anesthesia with large volumes. Absorption is higher, for example, if you inject it around the hip joint compared to a knee joint. Patient factors, age matters, elderly, the reduced clearance of local anesthetic due to reduced organ blood flow. They have a thinning of the myelin sheath, axonal degeneration, increased sensitivity of axons to the action of local anesthetics, So you would reduce the local anesthetic dose in elderly by 10 to 20%. In children, they have a lower alpha globulin levels, so and higher elimination time. So in children, you would also you would need to increase the doses of local anesthetics actually. And progesterone in pregnancy increases the cell membrane permeability to local anesthetic, decreases binding of local anesthetic by plasma protein, and they also have a lower levels of AGs, alpha globulins. So you would reduce doses of local anesthetics in pregnant. Patient factors, hepatic failure, for example, it decreases the clearance of local anesthetic with preserved plasma concentration, reduced dosage on average by 20 to 50% of the initial dose, depending on the phase of the liver damage. And a heart failure, if your patients got degree of heart failure, that decreased clearance of local anesthetic due to decreased blood circulation of eliminating organs and reduces the dose in severe cardiac coronary heart failure. In renal failure, high levels of high levels of renal failure will hyperdynamic type of blood circulation. Those should not be reduced except in terminal phase, where you would determine by your EGFR, by your glomerular filtration rate. When glomerular filtration rate goes really below 30, then you will have to reduce the dose of local anesthetic. If you are to use liposomal bupivacaine, IV administration is less safe despite it's in liposomes than with the non-liposomal bupivacaine, and the manufacturer recommends not to administer other local anesthetic within 20 minutes of liposomal bupivacaine administration. But we are far from a wide use of liposomal bupivacaine. The last prevention and presentation is the same as with bupivacaine. Interestingly, there is this concept of tumescent lidocaine injection where plastic surgeons actually inject enormous amount of a local anesthetic, and that is the publication by Klein by estimating maximal safe doses of the tumescent lidocaine. They infuse large volumes with adrenaline, and the American Society of Plastic Surgery recommends maximum dose of lidocaine dose for liposuction of 55 milligrams per kilogram, and a maximum dose without liposuction 28, and with liposuction 45. So beware that if you're working with a plastic surgeon, they inject enormous amount of local anesthetic, up to a liter sometimes, with adrenaline, relying on the fact that the absorption from local tissues is a lot less. But the risk of last in plastic surgery is higher. It's about 1 in 2,000. My surgeon uses lidocaine with adrenaline in this concentration, in 1 in 400,000 rather than 1 in 200,000. Remember that if you're using topical anesthesia for upper airway, safe dose of topical lidocaine is 9 milligrams per kilogram. And if you're using ever use Beer's block or intravenous local anesthesia, the recommended dose of lidocaine you wouldn't want to use anything else but either lidocaine or a prilocaine. Lidocaine is 1 to 3 milligrams per kilo is recommended dose. You would use a double cuff, and the seizures were reported with lidocaine as little as 1.4 milligrams per kilogram, and prilocaine and bupivacaine. So cardiac arrest was reported with 2.5 milligrams per kilogram of lidocaine and 1.6 milligrams of bupivacaine. So I would say that despite the recommended dose saying 1 to 3, I would not increase the dose of more than 1 milligram per kilogram. So either lidocaine or prilocaine is what you're going to use if you are ever to use intravenous local anesthesia technique, or sometimes known as Beer's block. Clinical presentation. CNS toxicity is the most common in up to 77%. 1/3 of last cases start with CNS, followed by cardiovascular symptoms. 1/5 of the last are isolated cardiovascular symptoms. Delayed onset. Sometimes it could be up to a few days, particularly if infusion is attached to the catheter, like we said before. And in 40% cases, the presentation could be atypical, as you would never, it's not classical CNS first, followed by cardiovascular. So CNS toxicity, described as a biphasic process sometimes. First is the excitation phase, presented by tingling, circumoral tingling and numbing around the mouth, ringing the ears, slurred speech, numbness around the mouth, tremor, dizziness, agitation, metallic taste, diplopia, followed by a CNS stage, a depression stage, where you have the patient will develop seizures, loss of consciousness, respiratory depression. Cardiovascular toxicity typically is divided in 3 doses, where the first stage is hypertension and tachycardia. And sometimes people quite often miss this dose. They think it's pain. That's why a patient is hypertensive and tachycardic. And the second stage will be myocardial depression and hypotension. That's what everyone picks up, by which time it could be too late. And then the terminal stage is the peripheral vasodilation, massive vasodilation, tachycardia, bradyarrhythmias, conduction disturbances, ventricular arrhythmias, and asystole. Right, this is the case of the sub-Tenon block with LAST. It's the male of 60 years old. This is the case that happens in our hospital, and where I acted as an expert witness, who had a retinal detachment and required a sub-Tenon block, which was delivered by giving 4 ml of 0.75% raw pivocaine, and which was not quite successful. So the surgeon kept topping up with 2% lidocaine to a total dose of 20. And because this is such a vascularized area, lots of it was absorbed, and the patient, it was recorded the hypertension up to 220 over 110, with respiratory arrest, loss of consciousness, intubation, anotropic support. CNS scan showed hemorrhagic brainstem stroke, which could have been caused by a massive hypertension originally precipitated by local anesthetic toxicity, and fatal outcome after 24 hours, unfortunately. How quick it is? How quick is last presentation? Less than 60 seconds if you administer it intravenously. That's why when you administer local anesthetic, using local anesthetic with adrenaline will give you the indication if you are injecting intravenously by developing tachycardia that you are administering intravenously. If it's partial intravenous, it could be up to 5 minutes, 15 minutes administration of maximum single dose for peripheral regional anesthesia. What would you do? Initial stage, stop the introduction of injection of a local anesthetic, call for help, airway, intubate if necessary, give 100% oxygen, hyperventilation may help a little bit to lower pH and metabolic acidosis. You would secure intravenous access if not already, and you treat seizures initially with giving either benzodiazepines or perhaps thiopental. In cardiac, in circulatory arrest, you would start CPR using standard protocol. You manage arrhythmias using same protocols. You would consider bypass if possible, and you would give intravenous emulsion. And we'll talk about the protocol later on. Without circulatory arrest, you would use conventional therapies to treat hypertension, bradycardia, and tachyarrhythmias, and you would consider intravenous lipid emulsion. And remember, propofol is not a substitution. Intralipid, let's talk about that. Guy Weinberg, guy in Illinois University, done some research, and you can see how he was in experimental animals injecting bupivacaine, injecting. Then he had a cardiac arrest, and then started CPR, and it was not successful. But with injection of bupivacaine, the same dose with lipid emulsion, he managed to successfully resuscitate that animal. So it was fortuitous that he found this cure. Possible mechanism of intralipid diverse local anesthetic from highly perfused organs like heart and brain to detoxification organs, muscles, and liver. Nobody knows quite for sure yet how does it work. Forms lipid volume in the bloodstream by diverting local anesthetic away from receptors, increases intracellular calcium. Fatty acids may prevent binding to local anesthetic to sodium channels in myocytes. It can improve cardiac output and blood pressure, enhancing the diversion effect. In our country, we have the guidelines by Association of Anesthetists of Great Britain and Ireland, where you would immediately give initial dose of 1.5 milligram per kilogram of 20% lipid emulsion and start intravenous infusion of 15 mils per kilogram per hour. And after 5 minutes, you give a maximum of 2 repeated boluses of the same dose, 1.5 per kilo, and leave 5 minutes between the boluses, and you can give up to 3 boluses can be given. So you would use basically what people do is they attach take 100 mils for 70 kilogram patients. You would give 100 mils over 1 minute, start infusion of 1,000 mils an hour, and after 5 minutes give another 200 mils boluses and continue infusion, but double the rate to 2,000 mils per hour. And it says do not exceed maximum cumulative dose of 840 mils out of that 1,000 mils bag. After successful resuscitation treatment, you would transfer to a intensive care unit, high dependency unit to monitor signs of pancreatitis. And in UK, we report to an agency called NPSA, and we also report to lipid rescue. So every case is recorded, and these are the guidelines that we have. Excuse me, that we have in place in every department. Last, prevention. How can we prevent it? Use ultrasound if you use the regional anesthesia. It reduces the dose required to block by up to 60-65%. Always use a test dose, whatever you use. Inject slowly. Inject in portions, intermittent administration, and pause between every portion. Use adrenaline and use the specific syringes. These are the syringes called NR fit, and these syringes can only be attached to a neuraxial needles or regional anesthesia needles. You cannot attach it to any normal needle or normal cannula. And these kits are now available for spinal, for epidural, for regional anesthesia. These are my references. These are intralipid references. And in conclusion, last is rare, but dangerous clinical situation. Compliance with doses and rules of administrations of local anesthetic is very, very, very important. Use ultrasound. That will reduce the dose. Sign of CNS toxicity appear first. Remember that if your patient's getting confused and complaining of dizziness, circumoral numbness, that is first signs of the local anesthetic toxicity. Remember, the first stage of cardiovascular toxicity is hypertension and tachycardia. Okay, hypertension and tachycardia. Remember that. That's what fooled my colleagues in our hospital. Have 20% intralipid available, keep it in the fridge, and know your doses. Ultrasound. Дякую за увагу, шановні колеги. you have listened to the presentation of local anesthetic toxicity. By finishing, I'm just going to encourage you to subscribe to my educational channel on YouTube, Dr. Vavinsky Anesthesia Education. If you don't remember, then just put my surname in English into YouTube search, and the channel with a lot of videos in English, Russian, and Ukrainian will appear, which you can watch, comment, like, subscribe. There's a lot of different presentations on regional anesthesia and airway mainly. And if you are to sit after this, completing your continuous education in anesthesiology 6 blocks of courses, if you are to sit European exam, then have a look. This is my book called How to Pass the European Diploma in Anesthesia and Care, available through all the good bookstores in the world, and also on Amazon. You can order it in hard copy, in Kindle version, and in EPUB version. I thank you for your attention, and wish you all the best in your continuous medical education in anesthesiology. It was a pleasure to talk to you today.